Imagine this. The doors of the emergency room fly open. A patient is rushed in, they're unresponsive. Their vitals are all over the place, nobody knows what they took, and the clock is ticking fast. This isn't a TV show, this is toxicology in the real world, and a life is literally hanging in the balance.
Okay, so you're in the thick of it. With a patient who might have been poisoned, your first instinct is probably to ask, what did they take? What was it? But here's the thing, that's actually the wrong question to ask first. So what is the number one priority?
The priority isn't about guessing the poison. It's about stopping the patient from dying in the next 5 minutes. It's all about stabilization. And the only way to do that is to cut through the chaos and apply a systematic, reliable approach that works every single time.
So here's our game plan for this explainer. We're going to walk through the life-saving ABCDE approach, step by step, and then we'll get into the fun part, the detective work of figuring out the poison by spotting patterns we call toxidromes. This is how we bring order to chaos. First things first, we need a blueprint. The ABCDE approach is the absolute bedrock of emergency medicine. It's a system that's designed to do one thing and one thing only, find and fix the most life-threatening problems first.
And the sequence here is totally non-negotiable. We always start with airway, because, let's be real, if you can't breathe, nothing else matters. Then we make sure that breathing and circulation are working. Only after that's sorted do we move on to disability and exposure. Let's break it down.
Okay, let's start with A. This is all about securing the patient's lifeline. A clear, open airway is the single most critical thing. If a patient can't get air into their lungs, no drug or treatment in the world is going to save them.
You see, in a poisoned patient, their reflexes can just switch off. Their tongue can fall back and block everything. Or worse, they can aspirate, which is a nice way of saying they could drown in their own stomach contents. We can open the airway with simple moves like a head tilt, chin lift. But if their consciousness is really low, or if a neurotoxin is paralyzing them, we need to intubate, put a breathing tube in, to protect that airway.
All right, let's move on to B and C. Now that the airway is open, we've got to check the engine room. Is the patient actually breathing effectively? And is the heart doing its job, pumping that oxygen-rich blood all around the body?
For breathing, we look, we listen, and we feel. We count their breaths, watch their chest rise and fall, and slap a pulse oximeter on their finger to check oxygen levels. But here's where it gets really interesting. The breathing rate itself is a massive clue. Breathing super slow, you gotta think of downers like opioids. Breathing way too fast, it could be a stimulant like amphetamines. Or maybe the body is trying to blow off acid.
Next, circulation. It's all about the pump. We check the heart rate, blood pressure, and how fast blood returns to the capillaries. The actions here are automatic and urgent. Get 2 big IVs in for fluids and drugs, draw a bunch of blood for the lab, and get an ECG on every single poisoned patient. Why? Because so many toxins love to mess with the heart's rhythm.
And blood pressure really boils down to 2 big problems. If it's skyrocketing, say from a stimulant, we use drugs called vasodilators to open up the blood vessels and bring it down. If it's dangerously low, we hit them with a bolus of IV fluids. And if that's not enough, we use vasopressors like norepinephrine to squeeze those vessels and crank the pressure back up.
You know, the exact same logic applies to the heart rate. If it's racing, we call that tachycardia. We can use things like beta blockers to gently slow it down. If it's plodding along way too slow, that's bradycardia. We use drugs like atropine to speed it up. And in some cases, we might even reach for a very specific antidote.
Okay, A, B, and C are stable. Phew. Now we can move on to D for disability. This is all about the brain. We're doing a quick check of the patient's neurological status, and we're hunting for 2 major emergencies.
And yup, these are the 2 big ones. A poisoned patient who's getting drowsy can slip into a coma in the blink of an eye. At the same time, other toxins can cause life-threatening seizures. Our job is to spot these and jump on them immediately.
Now, for the patient who's already in a coma, we don't have time to wait for test results. So we use something called the coma cocktail. It's this classic mix of treatments that we give right away, basically on the off chance that one of them is the magic bullet that wakes the patient up.
So what's in this cocktail? Well, oxygen is a no-brainer. Then we give dextrose, because a coma could just be from dangerously low blood sugar, which is an easy fix. We give thiamine, which is a vitamin that's often low in people with alcoholism. And finally, we give naloxone, the famous antidote for opioid overdose, which is an incredibly common reason for someone to be in a coma.
And to put a number on how conscious our patient is, we use the Glasgow Coma Scale, or GCS. It's a standardized score from 3 to 15 that looks at their eye, verbal, and motor responses.
15 is a perfectly normal awake person. A score of 3 means they're in a deep unresponsive coma.
We've made it to the last step of our primary survey, E for exposure and examination. Now that the patient is stable, this is where our detective work really kicks into high gear as we search for hidden clues on the patient's body.
We have to respectfully undress the patient completely to get a full look. We're searching for anything and everything. Are there needle marks? A snake bite? Is their temperature super high or dangerously low? What about their skin? Is it flushed and dry, or is it pale and sweaty? Even weird smells can give the whole game away.
And this is the payoff. All of those clues we've been gathering from the ABCs, from the physical exam, they start to click together to form patterns. In toxicology, we call these patterns toxidromes. Learning to spot them is like learning to read the poison signature.
So what the heck is a toxidrome? It's really just a toxic syndrome. It's a group of signs, like changes in vital signs, the size of their pupils, what their skin is doing, that all point toward a specific class of poison. It's an incredibly powerful diagnostic shortcut. Now, this slide, this is basically the cheat sheet for solving the case. Just look at the top two. Anticholinergic and sympathomimetic poisoning both give you dilated pupils and a fast heart rate. So what's the difference? The skin. Anticholinergics are hot as a hair, dry as a bone, but sympathomimetics, like from amphetamines, make you sweaty. That one detail can tell you exactly what you're dealing with. It's fascinating.
And this is why figuring out the toxidrome is such a game changer. It points you directly to the antidote. You see the classic opioid toxidrome. Coma, tiny pupils, slow breathing, you give naloxone. You spot the cholinergic toxidrome from something like pesticides. You give atropine. This is the system paying off, letting us give a specific, targeted, life-saving treatment.
So, here's the bottom line. When you're faced with the pure chaos of a poisoning, you don't guess, you apply a system. From ABCDE all the way to toxidromes, this methodical approach lets us stabilize our patient, find clues, name the poison, and give the right cure. It just goes to show, in an emergency, a system isn't just helpful, it's the difference between life and death. Which really makes you wonder, what other simple systems or mnemonics are absolutely essential when the pressure is on?